My name is Susan Rudiger, and I'm the Director of Development for the Charcot-Marie-Tooth Association. I started as a support group leader back after, like you've heard so many times, after my daughter was born. That's when I decided to get involved. Because for me and my 1A, I could always deal with it, but you pass it on to another generation, and the game changes, right? That's why we get involved. So I started the Atlanta support group, and I still live in Atlanta. And I joined the CMTA a few years back to help do some fundraising for them. So for all of you who have already given to the CMTA, thank you so very much. You are definitely supporting not only the conference like today, but you're also supporting all the work that we're doing on research, on putting out bracing guides, on putting out educational guides, on the PT and exercise videos you heard about. All that is funded by you and by the support you give to us. So thank you very much for that. For those of you who don't know, we have had recently a very generous donor come to us and offer a $500,000 gift to the CMTA for 1A. And that is on the terms of that the community steps up and matches it. So we have an opportunity right now to raise $1 million for 1A, and it's going on right now. So any gift that you make to the 1A match, which is easily found on the homepage of our website, or you could do it through the cards that are attached to those chocolates or on your donation form on the back, all of that will be matched dollar for dollar. So a $20 donation can easily turn into $40 for CMT 1A. And as you've heard earlier, that everything that we do for CMT 1A or any specific type really has overlap into all the other types. So by contributing to that match, you'll certainly help us propel research for 1A and all types of CMT forward. So thank you for what you've given so far, and thank you for considering and making another donation to 1A and beyond. So thanks. We're going to go ahead and get started with a question and answer panel. We have our esteemed panel of experts up here, and I am going to throw out a couple questions, and you guys can sort of work out who is best to answer them. I'm going to group them by sort of category, if you will, and I want to start off with Ken. If we can go ahead and start off with you, since you're sort of at the top of the mind. We got a lot of questions about bracing, as you can imagine. And one of the first ones was, what do you mean by ground reaction AFO?
Thanks. Good question. So a ground reaction AFO, the best example I give is a ski boot. If you're in a ski boot and you're standing in it and you lean forward into the ski boot, you feel the pressure on the top of your shin. If you lean back, you feel it in the back of your calf. The ground resisting that motion is what's causing that force up on the back of your calf and the front of your leg, and that's where ground reaction comes from. And that's how we interpret where we are in space when we have proprioceptive deficits. And so better yet, lock it into a ski, and you've got a really long lever in the front, really long lever in the back. Leaning forward then, you feel more pressure in the shin. Leaning back, you feel more pressure in the back of the leg, and that's how ground reaction works.
Thank you.
Yeah, welcome.
Thank you. And does it matter where the strut is, whether it's in the front or the back, the right or the left side? Does that matter?
It does not matter where the strut is. What matters is how strong the strut is. The strut should be rigid enough that it resists the motion forward, back, and in all three planes, actually. And if the strut is strong enough, you'll feel the resistance. If it's weak, then you'll feel very little resistance. And that's kind of the whole trick, finding out how much resistance is appropriate for your amount of deficit.
Thank you. Thank you. So we're going to move on to an exercise question. That was probably the best presentation I've seen on CMT and exercise, so thank you for that. It was so clear. I'm glad you guys thought so too. But the common question, and we hear it all the time at the CMTA, is how can people with CMT stay fit, and how can we exercise and really keep our pain at a minimum?
So in terms of staying fit, actually there's been a research study where I believe 15 or 20 people with CMT participated in 12 weeks of aerobic exercise, and they looked at the changes in the cardiovascular fitness. And the percent improvement that the people with CMT had was the same percent improvement that people without CMT had. So they had basically a control group of healthy individuals. So what I'm trying to say is that, yes, you can have aerobic fitness even if you have CMT. That's sort of separate from CMT completely, you know, like everyone in the population, that's actually the government guideline. Everyone in the population should engage in regular aerobic exercise, whatever aerobic exercise you can do. It doesn't matter if it's a simple cycle, like a little ergometer that you can put on the table to exercise your upper body, or if it's maybe a stationary bike that you can use at home or outside. So basically, the idea is to train your cardiovascular system for aerobic fitness. And again, that's the results that people have with CMT are the same in terms of training effect as people who don't have CMT. And then in terms of pain, I think you asked about pain. Well, pain again in different locations. For example, for foot pain or lower body pain, doing stretching and regular exercise can help prevent or minimize that. Another thing that I would like to point out, I explained, you know, I gave a lot of examples of exercise, and obviously everything needs to be tailored to the specific person. And so even doing just a little bit is better than nothing. So that's also a message I would like to put out. I don't want you to feel bad if you cannot incorporate all of them from the beginning, but just a little bit can make change.
Thank you. Certainly you gave us 5 minutes worth of exercise to start tonight, so thanks. Can't wait to stretch my heel cords. Seriously. Right, Ken? I need to stretch my heel cords, don't I? Okay. This is for one of the clinicians. Is there any knowledge regarding hearing loss in CMT? And will any of the trials address this possible secondary symptom?
Okay, I'll take that one. So yes, it's a topic that has gotten increasing attention. We know that patients with CMT1A do have an increased rate of hearing loss. It doesn't mean that everyone with CMT1A has hearing loss, but the frequency is increased. And we have started, I think, being more vigilant about that in clinics. So I'll ask about it more often and refer patients for audiology testing to have sort of a baseline if I have any concerns, and especially if I have a family history of other family members in that family that had hearing loss, because, you know, again, the disease just behaves differently in different people for reasons we don't yet understand. Treatment of hearing loss in CMT1A won't be any different than the treatment of hearing loss for other causes. It's a sensory neural hearing loss. And Mike Schei's group in Iowa has started looking into this more formally and looking at, large patient populations with CMT1A to really nail down the type of hearing loss, the age of onset, and things like that. So you'll maybe seeing papers about that coming down.
Thank you. So Paul and Pat, this might be for you guys. Might be the toughest question of the afternoon. It feels like night. When will the clinical trials of medicines be available for reducing the expression of PMP22? And I think that's a question that's on everybody's mind.
Well, I can talk to the small molecule part, but I do want to say that, one of the things that's great about sort of what you're doing with CMTA, particularly Pat, is you are sort of taking this multi-parallel approach, which, sort of hedges your bet to increase the opportunity to actually develop therapeutics. So different therapeutics can actually be developed at different rates. So, a drug that, is looking to sort of be a biologic or an injectable or something that's specifically targeting the mRNA will go a lot faster, towards actually reaching the clinic. So something with ISIS you probably see in, if you just start today, and I don't know exactly where the CMTA is on that, perhaps in something like, 6 years. Potentially in the clinic, because there's a lot of preclinical work that needs to do to validate that those modalities actually are efficacious and safe and they work well. With small molecules, what we're primarily moving forward in Sanofi Genzyme that we talked about, where we are now, it's probably somewhere between 4 to 5 years before we would get to clinical trials. We are at the stage now, and so keep your fingers crossed that we're sorting through a lot of molecules to see if there's an effect, and there'll be an effect in the animal models. We are seeing molecules that are having an effect in our in vitro models, and we hope that carries forward. So, there's always a risk that what we're doing won't move forward. But, we're hopeful, We're in this business, to really discover therapies for our patients. We have scientists that work around the clock and come in on weekends, to sort of run these projects and move them forward because they're really passionate about discovering therapies for these drugs. So we're working as hard and as fast as we can to move things forward.
Thank you.
Just a little bit to add in context. So when we started STAR, it was always our opinion and always the acronym Strategy to Accelerate Research is to get to a solution as fast as possible. The fastest way would be to take a look at the library of FDA-approved drugs in parallel to the small molecule effort that Paul just mentioned. We have done that, and we put it through the assays that Paul talked about. And we're looking at one compound right now that happens to be used for an indication in cancer drug that might have applicability to CMT1A. And so we're finishing up the animal model work there. Should that prove to be beneficial to the CMT1A animal model, I think that'll fast forward the pathway, if you will, to human clinical trials. So, stay tuned on that. With every compound, and Paul alluded to, you got to make sure it's safe. A drug for cancer is targeting a cell and wants to kill it. In CMT1A, I'm not looking to kill all the cells, right? So there's going to be some complications on working with that compound should it prove efficacious in these animal models that we're testing right now.
Thank you. So this is a really good question. Why is CMT called a rare disease when it's 1 in 2,500 people? Why does Genzyme care about it? Why are you all so focused on it? Why a rare disease?
I think, rare disease is a classification under 200,000 patients, I think is kind of the 250 is the classification. And it's also a genetic disease, so it specifies a particular population that is afflicted. So it's not the general population that we're looking to treat. I think that's why it's a rare disease.
Anyone else have anything else to add? No? Okay, let's go and talk about your INC clinic for a little bit, the Inherited Neuropathies Consortium and the Center of Excellence here at MGH. A very common question that came up quite a bit is the INC visit covered by Medicare?
The short answer is I think so. I haven't had any difficulty getting patients into the INC. On the other hand, I will admit that a large number of the patients who initially entered the center once we got it set up were those with private insurance. So the reason I'm hesitating is I think there's really only been a couple of patients, and I don't know if they have other insurance means that we weren't aware of. My sense generally in the neuromuscular clinic is it's not something that we struggle with. Would you guys agree with that, with Medicare? But we are happy to work with you on an individual basis to try to sort those things out.
So I have a little bit different slant on the answer. And INC supports 16, and we're adding 5 more centers of excellences. And I know of no instance that a person who wanted to go to the INC wasn't taken care of with or without insurance. I just want to make that clear. All right?
And then the follow-up question was, how do they register? How do they register with the INC to get into this research study?
So the easiest way is to just make an appointment, a clinical appointment at any center of excellence closest to you. And most of the time, we try to really respect patients' time, and the research effort sort of gets integrated into the clinic visit. And your primary care doctor would be usually the one to refer you. And with a diagnosis of CMT, it's usually a very straightforward referral process.
Let's move on to genetic testing for a moment, because that's on everyone's mind. And I would like to give a shout out to 2 of our corporate sponsors here. GeneDx and Invitae are corporate partners of the CMTA, and both of them offer pretty comprehensive genetic testing panels And for those of you who have the trepidation of the $20,000 price tag that you might have heard in the past, that is a thing of the past because of GeneDx and Invitae. And so if you are interested in genetic testing for yourself, you have to do it through a healthcare provider. But if you go through your healthcare provider and have the testing done by one of those two companies, it is quite affordable, and they both have patient assistant pay programs. So please don't let cost be a barrier to genetic testing for yourself. So thank you to GeneDx and Invitae for caring about the CMT community. If you also have questions, you can stop by their booths to ask about how that works for their testing. But let's ask a couple questions about genetics. People are asking, can 1A be passed down to their family members? And if so, could it ever convert to being a type 2 or a type 4 or a type X?
Can 1A be passed on from parent to child? Yes, it can. It's, as Dr. Friedman had mentioned, an autosomal dominant manner of inheritance. So each child has a 50% chance of inheriting the gene. Once inherited, it would stay true as a 1A. There would be no sort of morphing into another form. In other words, we think of it as a demyelinating neuropathy, and it would remain so in its character throughout its course. And
as a follow-up to that, with an X, can an X ever be passed from father to son?
No. I think that's the answer is no, it can't, because it is X-linked inheritance. So the father has an X chromosome with the gene and a Y chromosome. The father would pass that X chromosome on to an offspring. It would by necessity be a daughter who would receive an X chromosome from mother and would therefore just have one abnormal gene and would not express might actually have a mild the female might have a mild manifestation of the disorder.
So there's no father-son
No father-son inheritance,
with an
right,
X-linked.
right.
Okay, because father gives a Y to the
That's
son.
correct, yeah.
Okay,
Yeah.
thank you. And then does genetic testing show whether any CMT type is recessive versus dominant, or do you need the family history?
Yeah, there it comes back to family history, and as we've heard, autosomal recessive diseases would require the abnormal gene from mother and abnormal gene from father. The recessive disease requires 2 doses, if you will, to manifest the disease, whereas the parent has only 1 dose and is a carrier, asymptomatic carrier.
So genetic testing, you're talking to someone who went through this in my search for knowledge and understanding what type I had. And I did so for a couple reasons. One's to make the next generation better, but the other one was to understand what the probabilities were if I was going to have a kid. And recently found out that I never thought of the disease except in the terms of me, but I have a twin brother and a family who all shared guilt in not understanding why they didn't get it and I did. So the best comment or the best call I could ever think of was when I found out through sequencing that not only was it a de novo mutation, but I had the blood from my twin brother, my sister, my mother, my father. And I could make a call to my mom and say it wasn't your fault. It's so powerful to know what type and all the work that's on this stage right here. If we don't know what type you all have, we can't help. So I would encourage and implore everyone, if you don't know, have proof positive, use GeneDx, use Invitae, use that capability of getting diagnosed appropriately. It is one component I don't lose sleep over at all. And I just wanted to make sure everyone knew how important that was.
Thank you. Thank you. I'm going to wrap up with some genetic questions, and then we'll move on. If someone has sensory and motor neuropathy caused by their CMT, could they pass down only the motor without the sensory, or only the sensory without the motor?
It's a good question, sort of philosophical in some way. So the answer is yes. So what we know about these genes is that they don't all manifest the same way in every person in the family. So between families sharing the same mutation, we see people with different clinical presentations. And within a family, it's possible that siblings will not have the same symptoms as each other. And you can imagine that complicates things quite a bit. So it's not so much that you're passing down sensory or motor weakness. You're not. You're passing down an abnormal gene that in the environment, genetically and otherwise, in that new person may behave differently. You know, genes behave differently depending on all the other genes and all the interplay between them. So yes, your symptoms can differ from those of your parents, for example, and be more sensory or more motor, or milder or worse. And that's why it's always hard for us to predict when people ask how bad it will be for their children, exactly how bad, you know, it will be.
You want to add more?
I might put Vera on the spot here, but you know, the concept of modifier genes, and there's a lot of work being done to answer that question, why in a family of 1A is mom okay, or the brother's not in braces, or someone's in a wheelchair. And so the concept of modifying genes are pretty hot topic, and it's starting to show that, okay, so you have a defect in the PMP22 gene, but there's another gene that might be affecting the manifestation of that defect. So if that proves to be true, the good news is if you found another gene, you got another druggable target, and it should be fixable. So that's what I wanted to ask.
Yeah, that's right. And there's a study that's sort of from which the data is being analyzed now that Mike Shai has been working on within the consortium called the Genetic Modifier Study. And I think some of you have actually mentioned to me that you're involved with the study, looking specifically at why some patients who are very mild and some patients who are very severe with CMT1A, and they specifically recruited a population of very mild and very severe patients and are looking broadly at their genetic makeup, which is a really exciting thing that they're looking into.
Thank you. So we got a big stack, which is very common for these conferences, on nutritional supplements. What should we be taking? What vitamins, what things can I go to the nutritional store and buy that's going to make my CMT better? You guys are laughing.
I think we have an expert, like, nutritional person. I'm sort of embarrassed to answer the question. I think that the short answer to that one is we don't know. And so there's been no supplement that's proven in clinical trials to improve neuropathy, really CMT or otherwise. And so we don't have any credibility in saying to you with certainty you should be taking this or that. The way I approach it in clinic is I'll check, if it's never been checked before, at least in recent years, a few vitamin levels that can impact neuropathy. And if there's any deficiency or even a borderline low level in, for example, B12, I'll recommend that patients take some additional supplementation, because we know that deficiencies in those vitamins can cause neuropathy in their own right. So I don't want there to be anything compounding nerve health in a patient with CMT. But as far as just a healthy person with CMT starting to add a lot of things to their diet, I think most people would agree a really healthy, balanced lifestyle, diet, and exercise goes far longer than trying to take all kinds of supplements. And we worry about patients who take high-dose supplements, because we've seen the reverse effect of, you know, B6 is something that comes up as actually being neurotoxic, and so we don't like to see patients on high doses of that. So we're a little bit leery of it because it's a kind of terra incognita. I think there's a lot more work to be done to, you know, look into it.
Thank you. Thank you. Ken, I'm going to come back to you. This is a common question we get a lot. What do you do when your brace breaks and you don't have a backup set in your closet?
To steal from Vera, the short answer is you got to get it replaced. When the brace is broken, basically you're up the creek without a paddle, basically. So you've got to get it fixed. There is a big problem now with insurance coverage, especially with Medicare. Medicare has a 5-year reasonable useful lifetime rule. Medicare says that if you've been given a brace, it should last 5 years. There are 3 exceptions. One is that the brace was lost, and you don't need a police report or an insurance report, just a letter saying that the brace was lost. You know, I went to Disney World, left at the airport, whatever. And the other is that the brace was damaged in a natural disaster like Hurricane Katrina or something like that. And the third is that you've had a anatomical or a functional change that would necessitate a new design or a redesign of your existing brace, because that brace theoretically would no longer meet your medical needs. Other than that, Medicare is pretty tough on their 5-year rule. Here in the Boston area, Tufts Total Health has that same policy, which is kind of funny because it applies to children as well. So, you know, a 2-year-old is supposed to wear the same brace when he gets to be 6. You know, it's kind of silly. But that's the reality of it. Other than that, most insurances have an annual cap. Usually it's a dollar amount. But you have to check your own specific insurance to find out what your coverage is and how much insurance will pay for a replacement AFO.
And then on that question, there's a really big question between does insurance pay for the in-shoe orthotic, the blue insert that we like? Does it pay for the leg brace? Help us navigate insurance and
So
orthotics.
insurance coverage for AFOs, foot orthotics are much tougher. Medicare will cover a diabetic foot orthotic, but they will not cover a foot orthotic if you're not diabetic. And so it's hard to get covered. Now, there are some exceptions. Federal Blue Cross policies and actually United, you have to check your own specific coverage to see if a foot orthotic is covered, but by and large, they're not. AFOs, conversely, though, are generally covered. Every brace that I show you today, except for that really advanced one, is all covered with a very simple, generally accepted procedure code, and they're usually covered. You have to check your coverage if a brace, you know, some insurance only have like very minimal coverage. $750 could be a cap for your AFO, and it could cost $950 or $1,000. But you have to check that coverage and just see what it is. They all vary tremendously. But AFOs, by and large, are covered with clean procedure codes, and usually it's not a problem.
Thank you. Thank you for dispelling that myth. So what about AFO, or not AFOs, but orthotics for hands or bracing for hands?
Bracing for hands are same deal. They're mostly covered. Medicare has very specific guidelines for AFOs. They have these LCD regulations that we're all very familiar with. But when it comes to upper extremity, there is no policy. And so it's sort of the Wild West when it comes to getting upper extremity devices covered by most insurances, and by and large they are. So upper extremity braces are usually covered without a problem.
Do you do hand orthotics?
We do some. Occupational therapy tends to do a lot of them with low temperature plastics and things like that, but we do a handful of, no pun intended, I'm sorry, a handful of hand braces. We do a handful of upper extremity braces. Yeah, we certainly do. Most orthotists will. Yeah.
Thank you. One last question for you, Ken, and I don't mean to put you on the spot, and this is not a commercial, I promise. This is a legitimate question that came in. What are your top 5 favorite braces for people with CMT?
Oh, tough question.
That's a tough question, I'm sorry.
Yeah, I was
I'm
being
asking it.
I was being very sincere when I said that literally I fit every style of brace up there depending upon the patient and what their particular requirements are and what their particular preferences are. Everything from gadget tolerance to their specific deficits. I certainly have an enthusiasm for carbon bracing. Absolutely. That carbon bracing offers so many advantages when it comes to just normalizing gait patterns, restoring all 3 stance phase rockers, giving you back not just static balance but dynamic balance. Has a wonderful advantage that way. But depending upon the application, I'm enamored by this new brace from Montreal that I saw this morning that's pretty much indestructible and people can run up and down mountains with it. That seems pretty good too. For CMT, and then some people just with a lot of fixed deformity. That's why I showed that last brace I showed that was designed with a very static but well-designed molded inner boot and a rigid outer frame. It depends upon how much deformity, how much of it is fixed, and how active you are. So I would say the static brace, carbon braces, and Everything else is about equal.
So if you are looking for more information on the carbon bracing, the CMTA just put out in conjunction with Lower Extremity Magazine in late May, early June, the CMT Guide to Orthotics. And that was something I was really passionate about because I really didn't ever think I needed braces until one of our orthotists said, "Hey, Susan." And I said, "How did you know it was me?" And he said, "By the way you walk." I said, "I don't walk funny." He said, "Yes, you do." And I thought, oh my gosh, maybe I do need some braces. So then navigating the space can be very confusing. So we published a guide. You can find it on our website. I think we also have some copies outside. But there some specific braces are named if you're looking for brand names. They're all available through Ken and through orthotists. So here's sort of a big question for the docs. Do you guys really talk about CMT in med school? Like, why do our doctors not know what CMT is? And why does it take a panel of you all? Why do we have to come here? Real question.
It wasn't discovered back then, so.
Let me try to fix that. We do. It probably comes up for a couple minutes in a very packed talk about all of peripheral neuropathies. And I think, to be fair to the doctors who don't know about it, who are not in neurology, I think it's fairly inexcusable for neurologists not to know about Charcot-Marie-Tooth. Generally speaking, though, you have to imagine how many rare diseases, and even more rare than CMT diseases, are out there. And the medical school curriculum is 2 years of sit-down, lectures, and then 2 years on the wards. And a lot of that is acute medicine. It's people coming in for a stroke or coming in for a heart attack. And as much as some of those people may have CMT, it certainly wouldn't be on anybody's radar to be thinking about a chronic condition that's slowly progressive and not acute in the moment. So I think it's a problem not specific to CMT. I think medical school just isn't able to cover the scope of rare genetic diseases, and people who have a particular interest train additionally in it, later on. And that's okay as long as patients are referred appropriately to those people. So those are my 2 cents on that.
We're lucky if we get the medical students for 1 month on neurology rotations because there are so many branches of medicine they need to get exposed to during their final 2 years of sort of practical clinical training. So most of that education on CMT would come at the residency level. People who are doing 3 years of neurology residence post medical school. And there they may get the opportunity to rotate through different specialty clinics that would have exposure to that. But as far as the medical school level, no, I think it's very minimal.
Well, I think we're really fortunate here in the Boston area to have one of our centers of excellence with U3 experts and a whole comprehensive care team. And as you guys have heard, we have 17 centers of excellence around the world that are specializing specifically in CMT. So while it might not be necessarily in your backyard, there's certainly one accessible, and we're adding 3 more in the next year. So our reach is getting out there. We're getting the word, and you might have to travel a little bit to get to a really great CMT doctor, but that's one of the missions of the CMTA is to train more doctors and bring them into our fold and get them access to you and you access to them. So we're working on that together. Let's talk about some clinical questions around fatigue, around exhaustion, around pain. What is the role of fatigue and maybe the role of stress in CMT?
Okay. You guys are going to get tired of hearing my voice. So fatigue, I think, in my mind, is the main problem for the majority of my patients. So people who've been dealing with foot drop for a long time and numbness, they're used to that. It's nothing new. But they get to a certain age where their activities become more difficult, and they're finding themselves kind of wanting to just lie down in the evenings and not go out and do things socially. And I think that's really, really hard. And the truth is it's very tough to treat that. one of the things I always ask myself is, are patients physically exhausting themselves, and can we minimize that? So simple, very, very simple things like walking without braces with mild ankle weakness can be really exhausting, even when you don't have such bad foot drop that you're falling. And so sometimes we'll try bracing, and I have a patient will come back and say that their energy level has just improved so much from not having to do the extra work of lifting their foot that much higher, which is something we don't normally think about, you know, in those of us who don't have CMT. So fatigue is huge, and it's one of the toughest things, I think. Exercise can help, but again, to a point. So you have to do enough exercise that you're boosting your energy and not enough that you're exhausted the next day. And that's to the point that Sabrina was making. And I mean, that's difficult. But I think that with the help of a really good physical therapist who's knowledgeable, with the help of someone like Ken, you can strike that balance and then readjust that balance as time goes on. I think that's really key, to sort of revisit that depending on what else is happening in your life and with your health. As far as stress, I mean, I think stress makes everything worse. You know, and so it's not that the nerves degenerate faster and then you're not going to speed it up. I have patients who tell me they really worry that maybe they made their CMT worse because they had this really stressful episode when they were caring for a loved one or something, and maybe they didn't pace themselves. And that's not true. I mean, you can't speed up the disease, I don't think. We know very little about the exact biological influence of stress in any given situation, but my sense is that it's just something that makes it harder to cope with any chronic illness, and we want to minimize it as much as possible. But you have to first reduce the fatigue and reduce the pain, otherwise you can't reduce the stress.
Which goes back to exercise. Isn't that one of the best stress relievers out there? And deep breathing.
Yeah, I would say, I mean, I don't have much to add to what Vera just said. I think I completely agree. In terms of the fatigue, the bracing, maybe even intermittently or at times of higher demand, can help reduce fatigue, and then definitely exercising. When I was referring to the aerobic exercise in its many forms, it can have different sort of training effects. It's not just a matter of making your ankles stronger. That may or may not be achievable. The issue is, the aerobic exercise helps the overall cardiovascular fitness, sleep, mood regulation, and that's true in everyone. And that's why the government has those guidelines. Again, that applies to everyone, not just CMT.
So I have a couple notes on fatigue, and this will pile onto the supplementation question earlier. I decided to change my degree from biology to nutrition, and one of the reasons was I was hoping I would actually figure out how I can help myself now, right? While the research is going on, what can I do to get fit? And one of those parts was eating a healthy diet and losing 60 pounds, right? Which makes it a lot easier to walk. But I think most dietitians and clinicians with CMT are very conservative about supplementation unless you have a diagnosed deficiency. However, I bet a lot of people in this room actually have a vitamin deficiency that you're unaware of. And I just recently was feeling incredibly tired all the time, which is very easy to be like, oh, that's probably CMT. But I asked my MD to run a full nutrition panel and discovered I have a protein deficiency, right? That can lead to muscle loss and fatigue. I have a iron deficiency, fatigue. I have a vitamin D deficiency, fatigue, and bone loss, right? And I think I eat a pretty standard diet, okay? So I'm just being upfront, which is I'm a nutrition major, and I have major nutrient deficiencies that can make me feel absolutely exhausted all the time. And so if we already have CMT going on, I feel like one thing we can do is not pile on additional things, and taking care of ourselves and treating any diagnosed deficiencies is a big part of that.
I think fatigue is a very, very complex area, and I would certainly agree. There certainly is, a tendency to attribute everything to the CMT, but not always is that the case. And one of the things that sort of is our job is to try to identify if there are other easily reversible causes of fatigue, and sometimes it's very, very simple. There could be nocturnal sleep disruption from a number of things that could be a great contributor to daytime fatigue. There can be medication as side effects, people taking medications for other conditions and such. So There's lots of other things that we need to investigate to make sure there's not something easy to alter. But I think otherwise, then there's the rest of it's then in the camp of sort of energy conservation techniques, either through adaptive devices or various sorts of strategies.
I just wanted to add one thing to that. Yeah, that's a really excellent point, and I should have pointed this out too. And I always tell my patients, you know, just because you have CMT or really any neuromuscular condition, it doesn't mean that the symptoms you're having that are brand new and that weren't there the last 20 years are your CMT, right? So I recently saw a young woman who got really fatigued. I mean, not CMT fatigued, like extremely fatigued. And everybody kept saying it was CMT, and actually she just has a thyroid disease, which has been treated, and she's back to her normal level of fatigue, which is, you know, some fatigue. The other thing, to Bill's point, is that sleep apnea, the incidence of sleep apnea has actually increased in patients with CMT, and we're becoming increasingly aware of that. And I've definitely introduced questions about sleep apnea to my consultation for my patients with CMT. I have a very low threshold to get a sleep study. And reasons we don't completely understand, those patients do seem to have more difficulty. And as soon as you solve that, the fatigue level goes down.
Thank you. Thank you. Let's move on to some questions about surgeries. Tendon lengthening surgeries recommended for children with future bone deformities from muscle loss. Is that a recommendation?
Tendon lengthening for pediatrics, right?
Yeah.
So it's a hard question to answer because you really have to look at the individual patient. I would not say that universally tendon lengthening is indicated for any kid with CMT. That's not that straightforward at all. And I think you really have to look at the kid, at the range of motion. Is it correctable with something simple like braces? And I mean, Ken and I, in our adult patients, think a lot about this together. You know, how much can we actually reverse the injury? What can braces do? Is the person going to regain alignment with just, you know, orthotics and braces? And we really try to minimize surgery when we can. I'm not a pediatric neurologist, so I don't see as many very young children, but my sense is that that's an area of growing research and not one that has straightforward answers, and depends a lot on the degree of difficulty and the prognosis. You know, if this is a kid that's getting weak so quickly that we can't really expect them to be like ambulating, then you don't want to be doing surgery on that kid, you know. Whereas if they have a lot to lose and they're clearly forming severe deformity that can't easily be reversed, I think that the goal generally is to prevent the situation where surgery is necessary if you catch people on time, and more that's becoming the emphasis rather than chasing things surgically. But it's a very case-by-case situation.
What about hand surgery? Do we want to do tendon transfers for hand surgery or any other kind of hand surgery to help with dexterity or contractures?
Yeah, so this depends a little bit too on when you see the patient. I mean, sometimes we see patients who've had the disease for a very long time. They have such severe contractures that they need a surgical intervention of some kind. But I would say those are the extreme cases, and that more or less we can manage patients with occupational therapy, with devices, and avoid the need for things like tendon transfers. Because the truth is, in CMT, you know, healing is also can be an issue depending if there's sensory involvement, and there are risks to surgery. And they're not usually things that significantly improve function over what a really expert occupational therapist is able to do. That's my impression so far. I've referred no patients for hand surgery in the last few years within the center, but I know there are exceptions to that.
What about hip and knee replacements?
You know, I think that one would want to think also in terms of the specific situation. If somebody has bone-on-bone arthritis at the knee, and that can happen in people with CMT and people without CMT, even if you have CMT and that the pain is a primary driver in your lifestyle, I mean, you can still do the surgery knowing that the rehab program may have to be modified, and maybe the recovery period may be a little bit longer. It's not an absolute contraindication. And again, sort of going back to the idea that you know, we should not attribute everything to CMT, not the fatigue just to CMT, or you know, be worried about you know, we still need to treat people for common disorders, common problems that happen in anyone in the population. I mean, many things are very common. Arthritis is very common. You're going to have to treat it, whether you have CMT or not. Sleep apnea, thyroid, anemia, all those things that can contribute to fatigue or pain or worsening function in general. you need to treat it, and you may have to modify the rehab program to allow for a little bit of a prolonged recovery, but it's not an absolute contraindication.
Elizabeth's telling me I'm done. I had one really good last question. Okay, well, actually, you know what? The one last question actually can be answered by Herb. Herb Barron is our chairman of our board. Well, first, let's thank the panel. Thank you, panel. And while they're leaving the stage, I would also like to recognize Genzyme, the Sanofi company, who is represented here today. You've heard a lot about. They are one of our lead sponsors of the conference today. So thank you, Paul, and your entire team for helping to sponsor the conference. Another company that we're working with scientifically is Psychogenics, and they sponsored the conference. You heard me give a shout out to GeneDx and Invitae, so thank you to them. And then never to be forgotten, the illustrious Allard, which is a brace manufacturer. They're out there. I think I saw a lot of you trying them on. They are one of our partners as well. So thank you to them for sponsoring the CMTA. Herb, this last question, you're our chairman of our board, and I think you're going to answer this question. But believe it or not, somebody asked, what is the CMTA doing for people with CMT? Do you think you can answer that question?